Ladies and gentlemen, we also want to recognize the project director of JPIEGO. To the glory of God is in our midst this very wonderful afternoon. Ladies and gentlemen, a round of applause for Dr. Victor Adepoju. You're welcome, sir.
Okay, so today, just to introduce myself, I'm Victor, and I work for an organization called JHPIEGO. For some of us that are not familiar with JHPIEGO is an affiliate of John Hopkins University, and since 1978, we have been working to improve health of women and children around the world since 1978. We are present in over 40 countries. And our strength is maternal, child, and newborn care, even though we have started doing other things like infectious disease and all that. But our primary strength is maternal and child health all around the world. And we have also been a friend of Ondo State for many years. So today I will be showing us a presentation on crashing maternal mortality in Nigeria through nursing leadership. The Amplify experience with the introduction of new and lesser used WHO commodities for prevention, early detection, and treatment of postpartum hemorrhage. Next slide. So I don't need to tell us that postpartum hemorrhage is the leading causes, one of the leading causes of, or is the leading cause of maternal mortality in Nigeria. Yes or no? Okay. What are the other causes of maternal mortality after postpartum hemorrhage? Eclampsia. But if you look at PPH, it's around about 23%. That's like one quarter. So what that means is that for every 10 women that died in this country today, about 2 to 3 of them will be from bleeding uh, after delivery. Okay? So if you address postpartum hemorrhage, maybe you address eclampsia, you must have solved about 50% of the problem, right? And that's why this project has prioritized postpartum hemorrhage. It's called Amplify Project, which simply means accelerating measurable improvements towards improving impact for postpartum hemorrhage investment. Amplify. It's funded by United and is implemented by JHPIEGO in Nigeria. One of our consortium members is Shogun, Society for Obstetrics and Gynecologists of Nigeria. NANNM is also one of our consortium members. So before I go into the presentation, there is something I want us to do quickly. We have a quiz. I understand that you have a platform. So they will drop that quiz question in your platform. Just go there now. Go to your platform and respond to this quiz. It's just 3 questions. So when I finish my presentation, we'll do the same thing. You go back again and do that same quiz. Have they dropped it in the platform? Have they dropped? So can we all go to our platform, our nursing platform, and click on the link? Okay. So click on the link. It will take you to these questions. Right?
Hello? The link has been sent to the NANNM platform now. Please check.
Can we all see now? If you can see, let me see your hand. Oh, thank you very much. The other people are trying to load it. Let's quickly do it just like 1 or 2 minutes. Just quickly respond to them. I'll give us 1 more minute before I go ahead. NANNM platform. Let's go to NANNM platform and click. NANNM, sorry, NANNM platform. Oh, they said the link is not open. Oh. Ma? They should have done it without signing in. Oh. Taiwo, they should have done it without link, that they won't need Gmail. Open. They say some have opened. You don't need to sign to any Gmail. You just click on it. Okay, let me go ahead with the presentation. Next slide. The last data that we have is 2018 NDHS, and that gives us about 512 maternal mortality rate, about 512 per 100,000 live births. That's a lot. 512 for every 100,000 live births, according to the National Demographic Health Survey of 2018. Of course, we have a new data, but it's yet to be publicly made available. So what are the issues? We have issues around the quality of drug that we use to manage postpartum memory. For instance, there is a study that found out that about 60% of oxytocin that we use in Nigeria, they are not what? They are not quality assured. Most of our health centers, they don't have a refrigerator that you have to put oxytocin. So in most cases, when you are using your oxytocin, the strength or the quality of the efficacy that you need is not optimal, right? We have issues around poor knowledge, lack of awareness. So in 2020, the WHO came up with a recommendation following a trial known as the E-Motive trial. Can we all say E-Motive? So there was a trial they called the E-Motive trial that demonstrated that if we bundle some of the things that we do together, like bundle of care, okay, the impact on postpartum hemorrhage is very strong. For instance, medications like stable carbetocin, which is also like oxytocin. The stable carbetocin is just like oxytocin, it's an analog of oxytocin, but it's more stable. It can withstand high temperature, unlike oxytocin and all that. And that is what we use for prevention of postpartum hemorrhage. And it's a very good replacement for oxytocin, especially in rural settings or settings that access to electricity and all those things is a challenge. The other one, newly recommended product from WHO is calibrated drip. We all know how we have been measuring blood loss right up to now, right? We just look at the woman. Oh, this woman, he has lost 500 mil, he has lost 300 mil. We use pad, right? We use different things. Sometimes we use our, how would I call it, local knowledge, or is it traditional knowledge we call it? We just, oh, this thing should be around 200 to 300. But we know that all these things are subjective. In most cases, they are also inaccurate, right? So one of the new recommendations is also calibrated drip, which can help us to objectively measure blood loss, right? And then we can respond and trigger intervention as quick as possible. And the last of those recommendations is another medication known as tranexamic acid. Can we all say tranexamic acid? Okay. So you can see all these products, they are not new really, but they are new because they are lesser utilized. So WHO referred to these commodities as new and lesser utilized PPH commodities. Okay? And all those things, if we bundle them together, the E-Motive trial has demonstrated that the impact of PPH reduction and even on maternal mortality. Okay? Next slide. And you see, the country is also very strong on the roadmap for reduction of maternal mortality. In actual fact, the Honorable Minister for Health and Social Welfare, Professor Alipate, has a vision not just to reduce maternal mortality, but to what? To crash maternal mortality. To do what? To crash maternal mortality. That's the language that we are using now for maternal mortality. We want to crash it because it's such a high number. You can imagine a country of population of about 200 million plus, our maternal mortality ratio of 512 per 100,000 live births. So it's a big number. So we are not just going to reduce it, we need to crash it. And nurses stand at the forefront of this vision to be able to crash maternal mortality. So the E motive simply means, can we all read it? Can we all see what is on the board? So E is what? M is what? O is what? T is what? IV is what? E is what? Let's clap for ourselves. Thank you very much for following the presentation. So it's been demonstrated that if you combine these all interventions together as a bundle, what we refer to as clinical bundle, the impact of PPH is very massive. For instance, TXA has been found to reduce to about 61%, especially if you administer it within 3 hours of delivery. Okay? So these are evidence, and we need to scale up this evidence. We need to send the message across board, and that's why we have come here today. That's nurses in your various facilities, in your various practice. You need to create awareness about the emotive bundle. This is intervention that has been very effective. We started using this since March in Ondo State. We trained about 9 health facilities across 3 local governments in Ondo State. If you look at the data, PPH incidence data since March to date, if you look at maternal mortality, I'm going to show you some of those data. You can see that we have seen a very big impact of this emotive bundle on maternal death, on PPH incidence, and many other outcomes. So we need to scale it up across all the facilities in Ondo State and even across Nigeria. I think this is the key message for this presentation, to create awareness about the emotive bundle, to advocate for inclusion of this commodity in our procurement, in our hospital procurement, in state government procurement and maternity, so that beyond those few health facilities, all the health facilities in the state can roll out this emotive intervention. Next slide. Next slide. So unfortunately, you might not see this, but we are going to share the presentation. This is showing us an SOP on E-stable carpetosin. It has a lot of advantage. Like I told you, one of the benefits is that unlike oxytocin, this is what? Heat stable. It can withstand temperature of up to 40, even 41 degrees centigrade without degradation. You don't need to store it in refrigeration, right? You can use it, you can give it intramuscularly. IM, you can give it as intramuscular injection, okay? And many other benefits of E-stable carpetosin, okay? Next slide, next slide. So this slide is just showing us some of the other oxytocins that we have. If you look at the emotive bundle, the O is not oxytocin, right? The O is what? Oxytocin. And oxytocin we know can be misoprostol, it can be oxytocin, it can be. So we are not saying stop using misoprostol or stop using oxytocin, no. But we are saying that in terms of stability, in terms of quality, especially in those settings that we cannot guarantee the quality of oxytocin, this commodity has proven to be very useful for us. Okay? What is it? Do you want me to? Okay. So they want me to announce the owner of the vehicle, MUS 210GY. Your attention is needed. I repeat, MUS 210GY. Toyota Corolla. Which color? Huh? Toyota Corolla MUS 210GY. Thank you for your attention. Okay, so back to PPH. This slide is just telling you some of the benefits. When you look at misoprostol, you look at oxytocin, you look at ergometrin, all of them have their own benefit and use cases. But For HSC, I've told you what makes it to stand out in terms of use case that we can use in our settings. Next slide. So I think I've mentioned some of these things before. Studies have shown that when you use visual estimation to estimate blood loss for PPH, you are going to miss out 30 to 50% of blood loss. You are going to underestimate in 30 to 50% of cases. That is very huge. And the more the woman loses blood, the more the quantity of blood, the volume of blood a woman lose, the more the likelihood of underestimation with visual estimate, right? So calibrated drape is another technology or another tool that is very useful. For some of us that have not seen it, you can go to JHPIEGO stand there. If you want to see how a calibrated drape looks like, you can go to JHPIEGO stand. They will show you how a calibrated drape looks like. It's calibrated from 50 to 100 to 150, and you apply that on the buttocks of the woman, okay? After you've given your oxytocin or whatever oxytocin you are using, so that the blood collection can go into it, and that you can objectively estimate the amount of blood that the woman has lost. And you can trigger the bundle when that woman gets to a particular level of blood loss. Either the woman gets to 300 mils with some warning signs, or it gets to 500 mils without warning sign. You can trigger your bundle and you intervene and save the woman's life. Are we together? So we need to do a lot of training, a lot of awareness. We need to make sure that commodities are available at all levels. Next slide. So for Amplify, like I said, we are in 9 health facilities in 3 local governments in the state, Akure South, Owo, and Idonre. We are working with professional associations, community-based organizations, healthcare workers. We know that if you stay in the facility, you are not going to solve all the problems. Because one of the problems is that women stay at home. They don't want to come for institutional delivery. So the community-based organizations also go to the community, work through the World Development Committee, refer list pregnant women in the community and refer them to hospital for them to deliver, assess some of these interventions. So the community side of the work is also being handled by the CBOs. And like I said, you can see what I underline on this slide. That is the language I want us to be speaking. Okay? So the E-stable carbetocin is for what? Prevention of what? Of PPH. The calibrated drape for what? Objective measurement of obstetric blood loss. You can see it's from prevention to early detection to treatment. So that cascade follow each other. So for prevention, you are using your HSC. For your early detection, you are using your what? Calibrated drape. And for your treatment, you are using what? Tranexamic acid. So it's a flow. You prevent. After prevention, you detect very early with your calibrated drape. And after that, if the woman eventually come up with PPH, you what? You treat. Next slide. So I think I've mentioned some of these things. We are coordinating with Federal Ministry of Health on the supply side as well as on the demand side. You know that you cannot introduce any product, before you introduce any product in Nigeria, that product needs to be the reporting system, DHIS. So we are working with government to ensure that that product needs to be captured in the pharmaceutical reporting system, what we call the logistic management system. We are also working with them. Right now, this commodity are already in our NHLMIS, National Logistic Management System, so that when facility use this commodity, they can report it. Okay? We have done a lot of master trainers, training of trainer. In Odo State alone, we have about 16 master trainers in Odo State who can be called upon at any time by the state government to train at health facility level. And some of them are NANNM members. Okay? We're also working with Shogun, like I mentioned before, to also be able to do what we call the clinical mentorship, where they go to the facilities every 2 weeks to see what the healthcare workers are doing, the maternity staff. They look at their peer practice session, where they practice Mama Nathaniel, new Nathaniel, calibrated him and all that, like a kind of drill or demo sessions where all the nurses come together to practice before they use this knowledge on actual human beings. So these are some of the things that the project is doing to support the government, to support the professional association and the healthcare workers at facility level. Next slide. So for some of us that have not seen DRAPE before, this is like a DRAPE. And you can see the Honorable Minister for Health and Social Welfare trying to launch the calibrated DRAPE. Okay? And the good thing about calibrated DRAPE is that we don't need to import it from abroad. They are locally manufactured in Kano and Oyo State. So anybody, any facility or any government that need calibrated DRAPE, you don't need to order it from abroad. We have manufacturers in Kano and Oyo State that can give it. We can give you their contact and all that. That is where most of the states have been procuring, have been getting from. And it's also part of the vision of the government for made in Nigeria products, that we don't need to do everything from abroad. We can manufacture some of these things from our country. Calibrated DRAPE is one of the things that government has used to show that local manufacturing is possible in Nigeria. So as you can see, the vision, please, let me tell you before you move the slide. The vision of government is one DRAPE, one woman in labor, one calibrated DRAPE. I want everybody to echo it. One woman in labor, one calibrated DRAPE. One woman in labor, one calibrated DRAPE. Thank you very much. And that's what we want NANNM to push for at your various opportunities and settings. So you might also not see this, but in blue is the number of deliveries across these 9 facilities since January this year. Don't forget, this intervention started around March, April. So in blue is the number of delivery across those 9 facilities. In is that purple? Or what's that color? The next color after blue is the number of PPH cases, and the line is telling you the mortality from PPH. So you can see that after March, the line flattens out. We are not seeing any mortality from PPH case. Can we clap for ourselves? Can we clap for ourselves? You can see that before the introduction in March, you can see that line that goes up. That's PPH death from PPH. You can see that after the introduction of some of these commodity, you cannot see that line again. That's to tell you some of the early impact or early results of some of these commodities. And that is what we want to see. We don't want any woman to die again from postpartum hemorrhage. Next slide. Next slide. So I think just to highlight for us some of the things that nurses can do, and you are already doing some of those things. Clinical management, you are on the front line, you are the most times patients, you see patients, in most cases the first time they come to the hospital to deliver. So your clinical leadership is very key. And like I said, we have trained up to 168 nurses and midwives in the state on the emotive bundle. And we do a low dose, high frequency approach where we go to the health facility to call all the nurses and midwives over about 2 or 3 days to go through this training schedule because we want it on site so that you can use the knowledge on site, like a real practical approach to the training methodology. Of course, the quality of care is also very important. We want you to do a lot of advocacy in your various opportunity, in your, whether you are part of technical working group, you are in discussion with state government, you are in your professional association, you must be able to advocate for some of these products to improve the outcome for women who deliver. We also want you to also be able to use this in your training institutions. So all these things should be emphasized in your pre-service and in-service training curriculum, your continual professional development, which I believe is also part of this 2 days training that you are having. This has to be emphasized as well. Next slide. Next slide. Next slide. So what are the challenges? So one of the challenges we have seen is some of our hospitals, in most cases, they don't even have an incinerator. So one of the things that come up is this calibrated drip. How do we dispose it, right? Some hospitals don't even have an incinerator and all that. I can see one example we have seen in one of the states where people look for a local solution to their problem.